everyone, I'm Abbie Tipler and I'm one of the surgeons at Veterinary Specialist Services. Today we're going to be discussing the use of antibiotics and how you can use antibiotics in your practices without contributing to the overuse and the problem of antibiotic resistance. So I hope you really enjoyed this talk. It can be found in the vet resource area of our website at vss.net.au. I'll chat with you soon and we'll get started talking about antibiotics. So let's take a look at what antibiotics are good for. They have a great impact on non-surgical site infections like pyodermas, urinary tract infections and other systemic infections, but when it comes to surgical site infections, they actually have much less of an impact. And we need to be cognizant of the risks associated with antibiotic use. And these risks are firstly that you may leave resistant organisms to colonize the patient. Secondly, resistant organisms that are selected may colonize your hospital, making nosocomial infections, i.e. those that arise from the hospital, more difficult to treat. And finally, of course, there can be side effects from the drug itself. So we don't just want to prevent a post-operative infection. We also want to decrease the development of resistance, decrease the cost to our clients, and reduce the incidence of drug reactions by using these drugs only when absolutely indicated. However, there are some instances where we may want to use an antibiotic, and generally this is when we have a higher than usual risk of a surgical site infection. And as I mentioned, we discussed these risk factors in one of our other talks. However, a few examples are procedures lasting greater than 60 minutes, heavily contaminated procedures, for example a dog fight wound, and then orthopedic procedures where an infection may be catastrophic, even if the procedure is less than 60 minutes, which of course most of our orthopedic procedures are not. So when might you be able to avoid using antibiotics? A desexing procedure is a great example of a clean procedure that's less than 60 minutes. Your exploratory coeliotomies, where there's minimal spillage and good surgical technique is applied, and then lumpectomies, for example a lipoma resection. These are all great examples of where you may be able to avoid overusing an antibiotic. So what's the ideal antibiotic drug? Well, it would have a high safety margin. It would target the bacteria that we're likely to encounter during the procedure, especially our skin contaminants, which are a common source of infection. We'd want to reduce antibiotic resistance, and broadly speaking, this means choosing the narrowest spectrum of antibiotic that targets the bacteria likely to enter at the time of procedure. And we'll talk a little bit more about this in a minute. And then we also want the therapeutic drugs that we tend to treat our surgical site infections with to be reserved for when they do develop. So which bug are you likely to encounter where? And we can have, or I can certainly have, a notoriously bad memory, and there's nothing wrong in relying on tables. And this table will probably be a bit small to see on your screen, but we're more than happy to email this out to anyone tuning in, and it's a reminder of which bacteria we're likely to encounter for different procedures and which antibiotic may be an appropriate coverage. So I'm going to talk a little bit about cefazolin, and it cropped up frequently in the table that I just showed because it's great for targeting our skin contaminants which enter our surgical wounds. It's a safe drug. It comes as a powder for injection, and you add 9.6 mils to make it up to a concentration of 100 milligrams per mil, and then we tend to use it at a dose of around 22 to 30 milligrams per kilogram. And timing is important, and you want to give the drug at least 30 minutes prior to incision, but not greater than 60 minutes. And then we repeat this intravenously every 90 minutes during the procedure. And for high-risk patients, for example a systemically compromised patient with an implant, we may use it for up to 24 hours after the procedure. And it's actually quite uncommon that we use antibiotics beyond this point. And in fact, there was a study that linked the use of take-home antibiotics to an increased risk in surgical site infection compared with no antibiotics at all. And at VSS, we'd really only use a take-home antibiotic in the case of a patient with a distant site of infection or confirmed infection, and our choice would ideally be based on culture and sensitivity as soon as those results were available. We do not recommend a shot of antibiotic as an afterthought at the completion of surgery, for example a Clavulox or Convenia injection, for the exact reason above that we may actually be increasing our risk of surgical site infection. And we are almost certainly selecting for resistant bacteria if this is employed as a regular strategy. So it is important to note that there are a few studies that have shown a slight reduction in risk for infection when take-home antibiotics have been used for TPLOs. But it's not our usual protocol at VSS to send all these patients home with antibiotics, and we try to be selective in our use of antibiotics for all cases, including those with implants. So what are the take-homes? Well, be selective with which patients really need antibiotics and use all of your other techniques instead to reduce the risk of surgical site infection. And we discussed this in one of our other talks. If an antibiotic is indicated, use one with as narrow a spectrum as possible, which targets the bacteria you are likely to encounter. Time your dosing carefully and use them perioperatively versus dispensing take-home courses unless there's a really good reason. And I hope you enjoyed this talk. Please don't hesitate to email us for any further information or for any of the information that we've discussed here.